Cognitive disorders. Cognition, the process that is intellectual and perceptual and closely integrated with an individual's emotional and spiritual values. Cognitive disorders classified in DSM-4-TR are delirium, dementia, amnesic disorder, and cognitive disorders not otherwise specified. Cognitive disorders comprise a variety of assaults on the human brain. Cognition revolves around learning and memory. Loss of these fundamental abilities is a common thread in all cognitive disorders. In some disorders, these losses might be temporary. Cognitive disorders are divided into reversible and irreversible types. These disorders can span a few hours to many years and might or might not be imminently life-threatening. To cloud the diagnostic picture even further, patients might have more than one cognitive disorder or a coexisting psychiatric illness. Depression and anxiety are common in these patients. The prevalence of delirium occurs in 60% of nursing home residents age 75 or older, and 80% of people with a terminal illness will develop delirium near death. Comorbidity for delirium includes delirium always exists secondary to another medical condition or substance use, and then a comorbidity regarding amnesic disorders is secondary to an underlying cause. Changes in cognition might include disorientation, decreased concentration, loss of abstract thinking, and language disturbances, or perhaps delusions, hallucinations, and misidentification, which often results in fear. Patients might not be able to perform routine activities and may have forgotten the ability despite intact motor skills. The word delirium literally means out of one's furrow, which refers to the dramatic behavioral changes that the person might experience. The hallmark sign of delirium is its acute onset, which is key because the disorder rapidly develops in most cases. Other signs include a fluctuating level of consciousness, slurred speech, nonsensical thoughts, and day-night sleep reversal. The delirious patient might have visual hallucinations, for example, seeing multicolored rats, or have tactile hallucinations, during which the patient might feel bugs under their skin. The patient might pick at the air as if trying to do some routine task, such as opening a prescription bottle. The patient might be able to follow a conversation for a short period, followed by an acute bout of confusion. Emotions are on edge, and the patient might startle easily. The nurse should intervene quickly when delirium is suspected. Assessment and treatment of any underlying physical problem or illness should be addressed, because delirium can be life-threatening. 25% of hospitalized elderly patients who have delirium die within 6 months. Delirium has that rapid onset. The client will be anxious, fearful, and bewildered. An abrupt disruption in the perception of their environment exists. The disturbance in consciousness can be an awareness of time, place, and person, either altogether or just one of these. Often there are cognitive and perceptual disturbances with false perceptions of real stimuli or illusions, and there can be hallucinations. Primarily, those are visual and tactile. And then there will be short-term memory disturbance. There are subtypes of delirium. Delirium due to a general medical condition. There must be evidence in either the history, physical exam, or lab findings to show that symptoms of delirium are a direct result of a physiological consequence of a general medical condition. Such conditions include systemic infections, metabolic disorders, hypoxia, hypoglycemia, fluid electrolyte imbalance, hepatic or renal disease, deficiency states, post-op states, hypertensive states. Substance and many others. Substance abuse delirium. This disorder is characterized by the symptoms of delirium that are attributed to medication side effects or exposure to a toxin. So this can be medications, and there can be several different kinds. Toxins, that can include organophosphates and insecticides. You can have carbon monoxide poisoning or volatile substances such as fuel or organic solvents. There can be substance intoxication delirium. With this disorder, the symptoms of delirium may arise within minutes to hours after taking relatively high doses of certain drugs such as cannabis, cocaine, and hallucinogens. Substance withdrawal delirium. Withdrawal delirium symptoms develop after a reduction or termination of sustained, usually high doses of certain substances such as alcohol, sedatives, hypnotics. And the duration of the delirium is directly related to the half-life of the substance involved and may last from a few hours to 2 to 4 weeks. And then delirium due to multiple etiologies is used when the symptoms of delirium are brought on by more than one cause. For example, the delirium may be related to more than one general medical condition or a result of a combined effect of the condition and substance use. Some general thoughts on care for the patient with delirium is a frequent assessment, provide one-to-one care as much as possible. Often you'll need to provide a sitter at the bedside. Provide a room near a nurse's station. Remove or camouflage tubes. Cover up any IV tubing or IV sites with just a blanket sometimes. Provide a private room. I think I might have said that. Make sure that assistive devices are available, hearing aids, glasses, etc. Maintain that normal day-night schedule as much as possible. Provide a night light to diminish any potential hallucinations because of shadows. When communicating with the patient that is experiencing delirium, keep distractions to a minimum. Always identify yourself with each interaction. Reintroduce yourself. Speak slowly with short, simple words and phrases, and focus on one piece of information at a time. Never argue with the client. Provide information to the families. Let them know that this is temporary. And then provide medications if it's ordered and warranted. Essentially, you want to try to avoid any further medications in their body if we can help it. Talk with the patient about familiar and meaningful things in their life. Reinforce reality when the patient is having delusions or illusions. And then use reality orientation tools such as clocks, calendars, well-lit room, family pictures. Remember that delirium generally comes on quickly and the entire duration is brief, 1 to 2 weeks, and rarely longer than 1 month. Your long-term outcomes include that the patient will remain safe, they will be oriented to time, place, and person, and the underlying cause will be identified and treated. Medications can be used if needed, but they do carry side effects. For risperidol, the side effects can include agitation, insomnia, headache, and extrapyramidal symptoms. For Zyprexa, it is an antipsychotic, and side effects can include hypotension, dizziness, sedation, constipation, dry mouth. Haldol is also an antipsychotic, and the side effects can include dry mouth, blurred vision, orthostatic hypotension, and sedation. Dementia is a progressive deterioration in intellectual functioning, memory, ability to problem solve, learn new skills, and a decline in the ability to perform activities of daily living and impaired judgment. There are various types of dementia. Alzheimer's is the most common, and all dementias present with common symptoms. Defensive behaviors occur in early dementia. Often there's denial, an attempt to hide memory deficits. Confabulation is making up stories to preserve self-esteem when a person doesn't remember. Perseveration is the repetition of phrases that often occurs under stress. And then there's simply avoidance of questions. As a nurse, you will want to identify any general medical conditions that may be contributing to symptoms of dementia, determine any potential for self or other harm, and explore the family knowledge of the disease process as well as coping skills and use of available community resources. When working with a patient with dementia, always identify yourself and call the patient by name. Speak slowly using short words and phrases. Focus on one piece of information at a time, and talk with the patient about familiar and meaningful things. The person with dementia will have complex changing needs, and their care can be in a variety of settings: the hospital, home, long-term care facilities, and the community. So the care will be geared toward the patient and the caregiver's immediate needs. Somebody else will be involved. Some general assessment guidelines is that you want to always review medications the patient is currently taking. See if there's any interactions that could be contributing to the dementia. Determine the patient's current level of cognitive functioning. Are they able to perform activities of daily living? Do they know some safety guidelines in their home? And then determine if they need more safety measures, especially if they have any wandering risks, behaviors. Dementia of Alzheimer's type, commonly called DAT, has an average course of 5 to 10 years with a range of 2 to 20 years. Early onset often leads to a rapid deterioration. In the mild or stage 1 type of Alzheimer's disease, it's characterized by short-term memory loss, and complex tasks become more difficult. Concentration decreases while distractibility increases, and making accurate judgments become difficult. In stage 2, progressive memory loss continues. There's a decline in activities of daily living. Usually with that comes social withdrawal, and many may even forget their own address. Stage 4 occurs in stage 3 is moderate to severe, with a loss of activities of daily living. They can no longer dress or groom themselves. There's difficulty communicating. Institutional care is usually needed. And stage 4 is the end stage of Alzheimer's. Family recognition disappears. The patient will forget how to eat, how to swallow, how to chew. There will be mobility problems, and institutional care is needed. For the diagnosis of Alzheimer's disease, it is important to rule out any other causation, such as depression, neurological or medical problems, the effect of perhaps medications, nutritional deficits, fluid and electrolyte imbalances. Remember that there's really no definitive test for Alzheimer's disease. Studies such as the PET scan, CT, and MRI can diagnose cerebral atrophy. Mental status questionnaires are often done to increase early detection. Medications are given to help with Alzheimer's. The most common drug interventions restore neurotransmitters, and the primary neurotransmitter deficiency is acetylcholine. Common side effects of medications are dizziness, GI upset, fatigue, and headache.